My name is Felicia Citron. I'm a psychologist joining you from the ISPS conference in Pittsburgh. And I am pleased to introduce Jim. And Jim Gottstein is an Alaska-based lawyer now living on Maui, who founded the Law Project for Psychiatric Rights, Psych Rights, whose mission is to mount a strategic litigation campaign against forced psychiatric drugging and electroshock. He won 5 Alaska Supreme Court appeals, 3 on constitutional grounds, invalidating various aspects of Alaska's mental illness system. Jim is most known for subpoenaing and releasing secret documents showing Eli Lilly, the manufacturer of Zyprexa, hid that it causes diabetes and other metabolic problems, resulting in a series of front-page stories in the New York Times. He has written the Zyprexa papers about this and his representation of Bill Bigley, for whom he subpoenaed the secret documents. Jim is currently devoting the bulk of his time to the Mind Freedom Shield program and working to empower the protection and advocacy for individuals with mental illness, PAMI advisory councils. So welcome, everybody, and thanks so much, Jim.
Thanks, Felicia, and thank you, everyone, for coming. I don't want to be, I assume people can see that. I don't want to be too formal here. I'm really interested in what people think. They're not, I don't think it'd be, anyway, people are, feel free to interrupt with questions if that, kind of gets to be too much of a distraction, then we'll just save it for the end. So with that, I'll get started. The report on improving mental health outcomes was deliberately written for advocacy purposes with policymakers and potential funders. And I don't think that there's anything else quite like that. I think it also forms an evidentiary base for people resisting psychiatric imprisonment and forced drugging and forced electroshock. So the key, well, just to summarize, what our current system is doing, which relies almost exclusively on psychiatric drugs, is reducing the potential recovery rate from a potential 80% to 5% and average lifespans by 20 to 25 years. And just, dramatically reducing people's quality of life during their shortened time. And it doesn't have to be that way because there are other approaches, which this organization, really embodies, that do not involve coercion or force, and have, much better outcomes, like, approaching 80% without all the harm. So this is, okay, I want to switch now. I'm sorry, I just feel like I'm a little bit scattered. So this is the report, and I kind of wanted to show you what it looked like. And the point being is that it's really meticulously referenced. So, and those are hyperlinks that in most cases go to the actual source. If not, it'll go to like where you can buy the article and stuff. But most of them basically are links to the actual document. And so, it'd be very easy for people to dispute this, and no one has, which I guess, you could look at a couple different ways. One is that this isn't threatening enough for people to feel the need to try and dispute it. But I think basically it's indisputable. So even Thomas Insel, who was the director of the National Institute of Mental Health for a dozen years, basically said it does, the system isn't working. Things haven't improved in 50 years. In fact, the book that he wrote relatively recently is even more damning. And interestingly, he says, well, I believe that it's it's a biologically based thing. But that the most important things to treat, to help people are people, place, and purpose. So so it's biological, but the treatments are not that work are not biological. So I don't think that makes any sense. Okay. So the rate of disability of, on the basis of mental illness has gone up 6 times. Is it 6 times? Since the introduction of the so-called miracle drug, Thorazine in the mid-1950s. And I don't think all of it is attributable to the drugs, but I think the vast majority of it is. I think some of it is like this welfare to work change in welfare that happened under I think the Clinton administration, and that pushed a lot of people that were just getting maybe aid to families with dependent children on disability to continue to get support. And I think that is that idea is supported because when it was 2013, after 2013, they changed the eligibility. They made the eligibility requirements stricter, and so that it went down a little bit. So, maybe most of what that increase, which is what, 6 times, 6.5 times, is attributable basically to the drugs. So this is a study. It's from a study where I get the 5% recovery rate. It's Harrow and Job. They did this naturalistic study for 15 years, and people that were maintained on neuroleptics. I don't like to call them antipsychotics because they don't have antipsychotic principles for most. Had a 5% recovery rate, and this is worse than historically. I mean, way worse. And here's a bunch of studies. And again, all of these studies, there are references in the report, and with links to them. Okay, so it goes from 88% down to 45%, but generally in the 2/3 recovery rate or higher. And we have programs that have demonstrated much, the 80%. And the one that I keep coming back to, and in fact, ISPS published this book on the open dialogue approach, I don't know, a year or two ago. And I wish that I had read that book before we did this report, because I would have emphasized open dialogue much more, because I'm getting to be a firm believer that this is that the mental health system should be organized around the open dialogue approach. So just to kind of describe it, basically they have, you can see that they only have 20% people on disability. That's where the 80% recovery rate goes. And there's only 20% of people that have ongoing use of the neuroleptics. at the end of 5 years. And so I wouldn't say that there's 100% overlap between the 20% who are using, are on the neuroleptics and the 20% that are still or on disability. But I think that it's a very high correlation. And their basic approach is that they have two-person teams. When they get a call, one of those teams will respond within 24 hours in the person's environment. They don't bring them in to the hospital. They bring in all of the people that are important in that person's, the identified person's life, and they have this and they talk about things, and it's, I think, a fairly, you have to get training on exactly how to do this open dialogue discussion, but it's just very effective. And they basically eliminated the people diagnosed with schizophrenia in that part of Lapland, because you have to have those symptoms for 6 months or more to be diagnosed. And they were getting people through it before that. So I'm a big fan of open dialogue. And then in the US here, Lauren Mosier of blessed memory, he's beloved by psychiatric survivors. He did the Soteria-House study, and they got basically a 20% recovery rate too, or at least only 19% were maintained on the drugs during the follow-up period. And their big approach, their mantra was basically to be with people rather than to do to them. And they had this house, and there's sometimes it was kind of hard to tell who the staff members were and who the residents were. Of course, it wasn't locked. And people were just able to go through what they went through. It's not like they did nothing, but it was a safe environment. And I think and the expectation was that people would get through it. I mean, my experience is that the most important things for recovery is hope, and that there's someone that believes in you. And that's the exact opposite message that the current system gives, which is you have this incurable brain defect, and you have to take these debilitating drugs for the rest of your life, and the best you can hope for is to stay out of the hospital as much as possible and forget about doing anything meaningful. And that's, actually what I was told. I had 30 days in the psych hospital in 1982, and I was told I would never practice law again. Okay, so again, here's the long-term recovery rate for people on neuroleptics. And then if people get off of them, there's a 40% recovery rate. Excuse me. Excuse me. So while that's 8 times better than 5%, it's half of 80%. And what that really does is show that how important it is to try and get people through what they're going through without putting them on the neuroleptics. Now, there's still a 20% that we haven't figured out how to get through it, but 80% we can if we just quit insisting that everybody take the neuroleptics. Okay, I already talked about that. It reduces lifespans. I mean, one really important thing is that the the clinical trial literature is just mostly as unreliable is the kind of politically correct way to say it, but it's largely fraudulent. And even Marshall Angel, who was uh, editor of the New England Journal of Medicine, basically said that the medical literature can't be trusted. So, and as you can see by my background, I relentlessly promote my book. And the reason I mention it now is because it goes into kind of the fraudulent nature of Eli Lilly's studies regarding Zyprexa. I mean, they did such tricks as they would have this thing called placebo washout. And what they did, the so-called placebo group were people that were abruptly withdrawn from Haldol. Okay, well, that we know that when people are abruptly withdrawn from Haldol, that causes a lot of people to become, let's call it psychotic. And so that was a supposed control group. And of course, that would make Zyprexa look better, right? Okay, so, but that wasn't enough, even though for a lot of people, abruptly being withdrawn from Haldol would cause them to become psychotic or, worse. Some people really did quite well when they were withdrawn from Haldol, and they threw them out of the study. So there are other things that they did, but basically, the trial literature is very unreliable. A huge amount of it is ghostwritten. Most of it is written by the pharmaceutical companies. And the FDA is basically worthless in terms of regulating the drugs to make sure that they're safe and effective. So an example is that, as Bob Whitaker said in Mad in America, that 1 in every 138 patients in the neuroleptic trials died, and not one of these deaths were mentioned in the literature, and the FDA didn't mention it. Another thing is, and there was I watched the panel on involuntary commitment that was just before this one, and it was fabulous. And they had some, they did a study. There's this guy that did the study, which also kind of confirms this. Is the idea is that people get involuntarily committed because they're a danger to self or others, right? And the self is suicide. Well, involuntary commitment is massively associated with suicide. And that was confirmed in this recent statistical analysis of Allegheny County commitments. So it's not, it's making that worse. In terms of violence, that study also showed that it was probably making that worse too. So, okay. So, I'm a psychiatric survival, and one of our mantras is, if it's not voluntary, it's not treatment. And I mentioned Lauren Moser, who did the Soteria study, and he testified in one of my cases, and he was, such a prince. I mean, I had met him a few months before, and I had this case coming up, and I emailed him, and he hadn't responded to ask him if he might testify. And I finally called him, and he answers the phone. And he says, "Oh, I'm sorry, I just got back from Germany. I'm jet lagged. I don't have time to," because it was the next day at this point. "I don't have time to prepare." And I said, okay, I understand. And then he said, all right, I'll do it. And this thing highlighted here is part of the testimony that he provided, that in his career, well, okay. He says that, you know, if someone was going to do grievous harm, he would, of course, intervene, but he never had to commit someone because he established a type of relationship where they could agree on what they would do going forward. And I asked him, oh, do you have any, you know, much experience with, you know, people who are psychotic and not, you know, not medicated? And he said something like, oh my Lord, I probably have more experience with unmedicated psychotics than anyone alive today. And I find them among my most interesting customers. And so I think that's kind of the attitude that is really helpful. And that was the kind of people who didn't mind being with people who were crazy. I like the word crazy. Some people don't. And that's who he wanted for staff at Soteria. He didn't want people who were trained in, you know, in mental health, because it basically were, you know, trained in the wrong direction. And it turns out that basically psychiatric coercion, involuntary commitment, or which is a euphemism for psychiatric imprisonment, and forced drugging and electroshock, is actually a violation of international law. It's against the United Nations Convention on the Rights of Persons with Disability. And actually, my view is that in the US, the laws are, you know, are actually are not so terrible, but people's rights are just uniformly violated. So, I mean, here, this is a quote from Michael Perlin about how the courts and the lawyers don't care, you know, don't care about enforcing people's rights because they assume, I mean, the way I think of it is the lawyers appointed to represent people believe if my client wasn't crazy, she'd know this was good for her. And what this report does is show that that's just simply not the case. And the result is that no more than 10% of the people who are committed actually meet commitment criteria. And you can't, and in my view, you can't involuntarily commit someone in conformance with the United States Constitution. I mean, you cannot drug someone against their will under the United States Constitution legitimately, because you have to prove it's in the person's best interest and there's no less intrusive alternative. And neither of those things are true. And so from my perspective, the most important thing in terms of the legal system is that the lawyers assigned to represent people do so properly and get people's rights enforced, and that would solve a huge part of the problem. And that's why I'm involved in this PAMI Advisory Council Empowerment Project, is because the PAMI Act funds an army of lawyers, and its purpose is to quote, ensure the rights of individuals with mental illness are protected, including under the federal constitution, the U.S. Constitution, and state and federal statutes. And as we can see, these are just wholesale violated. And the protection and advocacy agencies are not, you know, fulfilling that purpose. And the advisory councils, which are required to have at least 60% people with lived experience or their family members are to jointly decide the priorities of the P&As, and they are just being squashed by the P&As, and so the idea is to empower them to assert their authority to jointly determine the priorities and make enforcing people's rights not to be psychiatrically incarcerated or drugged against their will a priority. And we're having a meeting on November 20th to get this going. I can hopefully put that in the chat, and you can email me if people are interested in attending that. Another category of people who are supposed to be on the advisory council is someone, a mental health provider, basically. Okay. So as bad as it is for the adults, it's just even more horrific that children and youth are being drugged so much, and the worst is really foster children. And if you think about it, children and youth, become foster children because there's been a determination that they've been the subject of abuse or neglect. Okay, well, that may or may not be true, but let's assume that it is true. That that would make children act out, right? And then you've got people, as bad as it is, being yanked out of your house is traumatic, and that would cause someone to act out. I mean, some children, are glad to be removed from that situation, but mostly it's pretty traumatic, even if they are being abused or neglected, and that would cause children to act out. And then these foster placements often are pretty horrific, and that cause children youth to act out. And so what these children are told is there's something wrong with their brain. They have to take these debilitating drugs for the rest of their life and forget about achieving anything. And again, that's just totally wrong. And they're not responsible for unacceptable behavior because of their quote mental illness. And so these are all exactly the wrong message. And what we should be doing instead is helping children become successful, including dealing with their emotions, and helping parents, be better parents, because they're under all these stresses too, rather than take them out of the home and drug them. They're virtually all drugged at one point, and often continuously. Okay, and so there's this critical think RX curriculum that goes through the information data on this, and there's a link to it in the report. And in fact, the principal investigator of that, David Cohen, is also a co-author on this report on improving mental health outcomes. So there are other things we can do. So I'm a big fan of peer support. There's kind of this true peer support. There's just a way that people that have been through it can connect with people who are going through it. It makes it easier to establish trust. There's kind of a natural empathy, and it's proven to be very effective. What the problem, it's become so effective that it's being corrupted and co-opted by the system. And so one of the tenets of true peer support is that there's no hierarchy, that that the peer and the person, learn from each other, And peers are now being, it's said to be peer support for them to enforce, quote, medication compliance. And so, that's not true peer support. Okay, so. And one of the places where this is it might even be taking off are these peer respites, where they're usually 7 to 10 days. People, can come in. It's a true respite. There was this International Peer Respite Soteria Summit. Geez, when was it? October of 21. Like 15 hours, 3 hours for 5 Sundays in that October. And there's a 5-minute video of Maddie, anyway, called How Afia House Helped Me, on YouTube. And there's a link there, and it'll be in the report. And I'll for sure put the links in once I get to the question and answer period. But it really, I think, is a good idea of what a peer respite should be. So I highly recommend that video. Okay. And then the World Health Organization has come on board, basically saying the world needs to change and use these voluntary approaches. Okay. One of the key things is housing. There's this program called Housing First, where people are provided housing, and you're not required to take the drugs. You're not required to get services. You just get housing. I mean, to me, it's kind of a no-brainer. What's the solution for homelessness? It's homes. And so that's basically been discovered. And another important thing is employment. I mean, one of the things that the system does, it says, oh, you're too fragile, you can't work, and it turns out that work is, very beneficial. I mean, you could say therapeutic. It gives, it makes people feel like they're contributing, that they have some worth. There's social aspects of it. It's hugely important for people to be able to work. One of the things we need to do is quit sending police when people are having, they're called mental health crises. Interestingly, there's a lawsuit going on in New York against sending the police, saying it's discriminatory and a violation of the Americans with Disabilities Act, because you don't send police to other medical emergencies. I kind of disagree that mental or emotional issues are medical, but I think it's an interesting approach and essentially right. Okay. I think I've really already talked about Soteria-Houses a little bit. There was this drug. Norway at one point said people have to have a non-drug alternative in hospitals, and there's this drug-free hospital that had fabulous results. And then the government changed, and they decided they weren't going to give support to private hospitals anymore. So that hospital closed, I think, a year ago, which was really pretty awful. And I think it demonstrates the difficulty in keeping beneficial programs going. Okay, open dialogue. I've talked to the Hearing Voices Network. It turns out that a pretty large percentage of people hear voices, maybe 10%. But it's really only those where the voices cause them trouble that get diagnosed with mental illness and locked up and drugged. And so the Hearing Voices Network is basically self-help groups that get together. And their big approach or mantra is what happened to you, not what's wrong with you. And they really help people deal with the voices, and they don't necessarily go away, but people can often learn how to function quite well, even if they do hear voices. I mean, some people find the voices helpful, but they're not the ones that get diagnosed with schizophrenia. Okay. I think you really have to, there's this big push in the US a couple of years ago for this national 988 suicide prevention line. And a big problem with it is they quite often call the police on people. And so that makes people not want to call. And it causes all these, other problems to cascade. And there's this book by Rob Whitepond, Your Consent is Not Required. And he talks about, what's happening with 988. And there's a recent report that came out about how often the police were called and how detrimental it is to the whole thing. But warm lines, they absolutely will never call the police. You can't have mandatory reporters staffing them. And they never do anything that the person doesn't want. Okay, so, and then there's emotional CPR, which is kind of a response to mental health first aid. I don't know how much people are familiar with mental health first aid, but my take on it is it's basically getting people to call mental health authorities on people, but this is a different approach that really helps people get through what they're going through, basically through human connection. Okay, and then of course psychotherapy, which I think is a big thing with this group, has also been shown to be quite effective. I don't know if people here remember Bert Karen, who's a big it's a fabulous psychoanalyst who's very involved in ISPS and other organizations. And you can see why he was so great. But he did this study, the psychotherapy of psychosis or something like that, and wrote this book and showed that psychotherapy can be very, very successful even with people who are experiencing psychosis. Okay, and there are a lot of other person-centered approaches. So I'm not going to go through all of them here. And that's basically it. So I feel like I was a little scattered, but hopefully I got through it. Do people have any questions? Oh, you want? Mhm. Go ahead.
Thank you for that excellent presentation. I wanted to just alert you to the chat. Catherine requested the publication date and where the report is available.
Yeah, I'm just going to do that. It was published in September of 2023, which was just a little over a year ago, and I'm going to put a link to it in the chat. Okay. Thanks, Lori. Anything else? So, I mean, Lindsay?
Hi, yes, thanks so much, Jim. I'm a psychologist in Chicago and am involved with a bunch of folks who are also very involved with ISPS, and unfortunately didn't know Bert Karen myself, but many of them did. So I'm happy you're acknowledging him in this space. And we find ourselves in this really interesting moment where we're about to start having some formal meetings with legislators kind of up and down at the state level, talking about how we might reform, improve, get some protections in place around the mental health care system in Illinois. And we've been kind of toying with language around we need to stop an expansion of mandated care and kind of looking at, what's happened in California with the care courts and things going on in New York. And I'm curious in your view, where do we start? What is your thought about where we start, kind of with this idea of more legislative advocacy or protections that might go into place as we're kind of up against this push for more coercive care and this idea and I think the public, that this sometimes is treatment.
Well, I mean, I, you know, that's kind of the $64,000 question is how do we, I mean, the key thing is, I think, to change public attitudes. And how do you do that? I've been trying to come up with an effective strategy for that for over 20 years. And I think we just have to plug away at it. I mean, that's the purpose of this report was for policymakers. And I know it's long and it's kind of academic. So I just put in the chat like a much shorter piece with a lot of graphs. I mean, there are graphs in the beginning of this one too. And I'm going to put in the I should have had all these queued up. Then there's like a 97 second video I did on, let's see. That I think kind of describes it. I just put the link to that. Oops, it says 3 seconds. So I think it's kind of an all of the above approach. I mean, I think, you need to have a short document for legislators. The staff people, I think you give the longer document to. I think having people testify as to their experience is good. I try and accept all speaking, invitations. I'm not traveling these days for health reasons, and so that's in some ways, I mean, that's makes it difficult, but Zoom came in at just the right time. So we can do things like this. In terms of actually getting something done and enforce people's rights, this PAMI Empowerment Project, I think has the potential to be the most impactful thing I've ever done. And there's a meeting on the 20th, 6:30, I think, Eastern time. I'm going to put a link to the registration for that if people are interested. Because as I said, there's this army of lawyers funded by the federal government, and they're supposed to ensure the protection of people's rights. And they're just not. And there's a mechanism that should be able to correct that. And that's what the PAMI Advisory Council Empowerment Project is designed to do.
Thank you.
Thank you.
Can I
Sure.
have a question, please, Jim? Just around where did this idea come from that where you have scientists, I think a lot of the public's view of psychiatry is down to a view of science that is the answer to our problems, and it informs a lot of policy, it informs a lot of our direction as a society. And yes, there's so many shortcomings and health implications with much of our science. So as we look upon the 19th century and the hatters who used to make their hatters with a host of chemicals, but one of them was mercury. And the hatter using mercury very often, they would become mad because, like in the old sense of the word, because they were using that chemical the whole time. In terms of modern society, we have plenty of additives, chemicals, psychiatric medication itself, which causes difficulties in terms of damaging the brain or chemical damage of the brain. And so the standards haven't raised a hell of a lot that we think it has. It hasn't gone as high as we think it has, and that's the societal perception. But I think governments are trying to use that heightened standard idea to sell their, the society that we live in, to sell different political ploys.
So I have a couple of thoughts about that. One is that is that there are some physical things that cause mental issues. I mean, one that's you mentioned the mercury. One that's really common and goes undiagnosed, as it gets diagnosed as a mental illness, is Lyme disease. That happens a lot, and then people get hammered with psychiatric drugs instead of treating the Lyme disease, and that becomes a huge problem for because the problem isn't being addressed, and B, they're introducing new problems. But if it's got a physical problem, that's not psychiatry, that's neurology. And so that's kind of one aspect of it. The other is historically, I think you asked how do we get there, is that psychiatry used to be psychoanalysis, and then other forms of psychotherapy, but then it became where you didn't have to be a medical doctor in order to practice psychotherapy. And so the docs, I think, made this unholy alliance with the pharmaceutical industry to basically promote that these were, physical illnesses, and and then they have the monopoly prescribing privileges, although maybe not, that's changing a little bit. But in any event, the idea is that so they then continued control over this this problem of people misbehaving and being attributed to mental illness. And so I think it was basically just for financial reasons. And boy, talk about it, marriage made in heaven or hell, I suppose, the pharmaceutical industry and psychiatry. So yeah, I see, Sherilyn, you mentioned traumatic brain injury causes psychiatric symptoms, but requires different treatments. But I would say that, things that get diagnosed as mental illness also require different treatment than what they're getting.
Yes, I agree. Thank you, Jim.
You bet. So, I mean, one of the things, people just jump in, but one of the things that I'm really interested in hearing from people is how they think they might, use the report on improving mental health outcomes to kind of achieve these things. I mean, the idea of legislators have come up. I've been from, I think lawyers representing people should be using it. But any ideas that people have? I think social media. I've, I have a number of videos out, and that one I did, I think, has a few thousand views, but I'd hardly say it's gone viral. So I'm just interested in what people think about, how to go about this. Yeah, that's my feeling too. It's hard.
One thought that I had is I'm involved in the training program of psychologists and psychiatry residents. And so taking this back to them as well and integrating that in their training is one step that I imagine maybe, even if it's not getting to policy level, getting to some of the providers.
Yeah, absolutely. I mean, it was interesting. I think most people are familiar with Robert Whitaker, and his kind of most famous book is Anatomy of an Epidemic. But before that, in 2002, he wrote Mad in America, which actually is what got me started on psych rights, because in addition to being a great read, to me, it was a litigation roadmap for how to challenge forced drugging, not just based on the civil rights aspect of it, but that it not being in people's best interest. And that's actually why I formed Psych Rights, was because after reading that book. And I brought Bob up to Alaska to give some talks and stuff. And one of them was at the Alaska Psychiatric Institute, and they had the psychiatrists there and stuff, and talk about going into the lion's den. But my sense of the room was, even if we agreed with what you're saying, which we basically do, we wouldn't be allowed to do what you suggest. And so I think we just have to keep plugging away at that. And I wrote this paper, and there's a video on it too. The video is about an hour long, and the paper was in 2005, about a conceptual framework about how to go about this. And the most important thing is changing public attitudes. And there are three, what I call it the transformation triangle. I'll put a link into it. There are three, three parts of the triangle. Changing public attitudes is at the top and the most important. And having other alternatives or other choices is another end of it, or angle. And they reinforce each other. So if people knew that these other approaches work better, they would support having these other approaches. And to the extent you have these other approaches that work better, that will help change public opinion so that's a self-reinforcing positive feedback loop. And then down at the bottom, then the third one is enforcing people's rights. People have the right to the least restrictive alternative with respect to psychiatric imprisonment, and the least intrusive alternative with respect to forced drugging. And that's even though the Alaska Supreme Court got this wrong, but that's a limitation on the government's power to impose these massive deprivations of liberty. Is you can't impose this level of deprivation if there are any less restrictive or less intrusive alternatives. So you can, if people's rights were enforced to that, if you could go into court and say, stop someone from being locked up because they could be sent to a Soteria house instead, they shouldn't be locked up even if there is no Soteria house actually in existence to send them to. Okay, well, so that could, that could really kind of encourage or force the availability of such alternatives like Soteria-Houses or Peer-Respites. But judges, are pretty reluctant to let someone go because there's a theoretical possibility, a theoretical alternative that doesn't actually exist. So if you had those alternatives, that would make it much more likely that people would, the right to those alternatives would be honored. And then the third reinforcing link between enforcing people's rights and changing public attitudes is a little bit harder to see, but it may not be so true anymore. But before the Brown versus Board of Education in the United States, where the U.S. Supreme Court said that segregation, mandated by law is unconstitutional, there were a lot of people in the U.S. who felt like segregation was okay because the Supreme Court had said it was. But after Brown versus Board of Education, I think public attitudes dramatically changed. And until, the Trump era, and I don't want to get into politics, but until, I shouldn't even have said that, but until relatively recently, from then until relatively recently, you could hardly find anybody who would support segregation. And maybe there's been a little backsliding on that recently. But I think that's an example of how litigation can influence public attitudes, and the other way too, to the extent public attitudes realize how bad the psychiatric incarceration forced drugging is, and that will tend to support people's rights being honored. Okay, I think I see you getting a little fancy, Felicia. I think.
Well, I wanted to alert you to a couple other comments in the chat as we have just a couple minutes left.
Right. So I guess, are you talking about the last two?
Yeah, so Lori was saying, she said, on our rural island community, we're slowly building supportive housing. Your report is our #1 resource at this point, and I really appreciate having it to ground us.
Thanks, Lori.
And Farrellyn also said people rarely talk about the negative side effects of weight gain, tardive dyskinesia. There's no real informed consent.
Right, and there was a recent California Supreme Court on electroshock, which basically said that the electroshock machine manufacturer did not give information for people to provide informed consent. And if you don't provide informed consent, if you don't obtain informed consent, in some states, I mean, historically, that's actually a battery, a personal injury battery, a tort in the legal sense. It's been changed in, some states to more like it's, malpractice. The problem being that malpractice is defined by, the doctors get to define what malpractice is by what they're doing. If it's what they're doing, then it's not malpractice. So anyway, yeah, the huge weight gain on Zyprexa, like people gained 100 pounds in a year. Tardive dyskinesia, they lied about the newer neuroleptics, like Zyprexa not causing tardive dyskinesia, and it turns out the rates are just about the same. People can die from neuroleptic malignant syndrome. I don't know if people know about Esmond Green in New York. I think maybe it was about 10 years ago. She was in the ER, psych ER, I think, for 24 hours. And she keeled over, and staff members just walked past her, and one even kind of nudged her with her foot. And it turns out she died of deep vein thrombosis. And I pointed out to the coroner that I think she was on Seroquel, that Seroquel causes that, and he should change the coroner's report. And of course, they said, no, they weren't going to change. So, yeah, I mean, people just don't have any idea, the general public, until it happens to them or a family member or friend. So that's the big trick, is how do we get the public to understand all this stuff?
Thank you so much for this talk and for everyone joining in. Any final thoughts or questions as we wrap up?
Buy my book. No, we get the, what else did I say I was going to do? Well, I'm going to put my email address in the chat.
Lots of gratitude coming through in the chat as well.
Well, thanks everybody for coming. So.
All right. Take care, everybody. So long.